first thing, always wash the hands. That's one thing that's going to flunk you out, fail you, or get you get a ding by your preceptor in clinic or hospital, because it's a safety violation. Okay, so that's hygiene, and hygiene is for infection control. Right? So you guys know that. Then we're going to do our two identifiers. Can you state your name and date of birth for me? Show me your wristband. Okay. You want to have your patient do as much for you as they can. So you don't want to be pulling things down. Hey, hi, how's it going? Oh, Mr. Happy's there. So we want to have the patient maintain patient privacy. We want to maintain patient dignity as much as possible. So, okay, state your name and date of birth. We check our two identifiers. And we're just doing a general survey as we're talking to them. Are they responding? Okay. If they're able to spontaneously respond and spontaneously open their eyes and turn and look at you, they are alert, right? Okay. If they know their name and date of birth, they are alert and oriented person. Okay. Do you know what hospital you're in? I'm in St. Cloud Student Lab, place. Do you know what day it is? October, I don't even know what day it is. Time, alert and oriented times 3. Okay, that's different. Alert and oriented, that's one documentation. Then there's level of consciousness. Level of consciousness is spontaneous. So if they spontaneously open their eyes and look at me, they're spontaneous. If they are arousable, okay, and again in your textbooks you look at the different levels of consciousness. I want you to distinguish alert and oriented times versus LOC. So maybe their eyes are closed and you have to kind of wake them, you know, hey, wake up, John, okay. But then he opens his eyes and he's okay, he's still alert. But if he's sort of obtunded and not opening his eyes, then he's difficult to arouse. There's different scales that different hospitals use. I always look at the policies and procedures wherever you go and you rotate. Look at the policy and procedure, look at how they chart, and see how they want their documentation done, right? If the patient's non-arousable, hey, wake up, he's not waking up, what can we do? Yeah, we can do pain. We can pinch them. A very noxious stimuli, if they're very non-arousable, you can use a pen and squish it against their fingernail bed. It's not going to hurt them, but it's going to cause a significant amount of discomfort, so they might wake up. So are they arousable? Are they alert and oriented? We document that. I'm looking at a general survey. What is a general survey going to include as we're looking at our patient? Do they look appropriate for the situation? Are they in any apparent distress? Are they grimacing? Are they diaphoretic? Are they flushed? Are they pale? These are all critical things. You walk in the room and somebody's diaphoretic and pale, I'm really concerned, right? Something's wrong. I'm worried about circulation, worried about perfusion. So just in general, how do they look? General survey. On my general survey, and correct me if I'm wrong, but I like to talk to the patient after I've done the first things, ask them their identifiers instead of, and we're talking to them. We're looking at the bed, the floor. We're looking for safety concerns, if they have any IV lines or tubing. I follow all my lines from the pump, make sure it's the right solution, that it's hung up right, that the tubes aren't inverted or something, that there's no bubbles in the line. I follow it to the patient. Hey, I'm just going to take a look at your IV site, and I can just pull the covers back and take a peek. General survey. It's okay in your general survey to say, hey John, can I just take a quick peek at you here? How does everything look? What am I looking for? What might I be looking for here? Yeah, you could see integument stuff. You could see color. Sometimes you'll pull this back and there'll be a big pool of blood because they pulled their IV out and they covered it up because they don't want you to see it, or they're sleeping or whatever. So surprise, surprise. Needle caps, needles, boxes of Kleenex, towels that are used to get shoved in bed. So I'm just general survey. I'm looking for those things that shouldn't be there. Did he pee the bed? Did he stool? So is he cleaning? You know, does the bedding look like it's okay? We're going to change it eventually. Places have different schedules. They change bedding, but we're checking that. Looking around, making sure that everything looks good. Check all my tubes and lines. If he's got an NG tube, I'm making sure, looking at the suction canister. Is the suction on? Is it set appropriately for intermittent or continuous? So just kind of a general overview, okay? So he looks okay, his color's good, he's responsive, he's alert and oriented times 3. Alert and oriented times 4 would be purpose. What brings you here? Okay? So he says, well, I'm here because I had a hip replacement. Then he knows why he's here. So So it gives us an idea of cognition, frontal lobe function. Then, once I've done my lines, and you'll see that lines and tunings are down here, I bring it up here, and I think we're on the same sheet there.
Yeah, and you have this sheet that Chris is using. You have this study from it was printed off of Blackboard. You should actually probably have it here with you. So.
Okay.
Yeah.
So, now this is one confusing thing that comes up. I think it's pretty straightforward for you guys, so just to be standard, you could do vital signs next, okay? So do you do vital signs and then it's moved to your head to toe?
I did, and that's what we have
Okay.
been doing yesterday when we've
Perfect.
been doing our sims. And
Okay.
for me, the most important is that you do them together,
Right.
and all of them.
The
Do a
vital
blood
signs.
pressure and then
Yeah.
assess, and then do a pulse and then assess.
What do you mean?
Like do them all at once. Don't like yesterday they were
Oh.
scattering. Like they do the blood pressure.
Temperature
and
and
then,
then,
5 minutes later they
Okay.
do the.
oh, okay,
Yeah,
yeah.
so
I
do
mean,
it.
I would, have your vital machine with you when you came in. Make sure that it's been cleaned and wiped down. You got the right size cuff. You want to make sure you get an appropriate size blood pressure cuff, et cetera. All those things that you've already learned. And tell them what you're doing. So I'm going to get your vital signs, which is going to be taking your temperature, your pulse, respiration, and blood pressure. Don't talk to a patient in jargon. That's not patient-centered. I'm going to take your vital signs. How's your IV doing? What's hanging? They have no idea what you're talking about. What meds are you on? Normal people don't usually talk about meds, unless they watch Grey's Anatomy or something. I guess I'm dating myself.
You see it say ER.
Right. So you want to explain what you're doing, and so we collect our vitals. We get our temperature, put our temperature probe in, just hold that there. Put the blood pressure cuff on them, hit the blood pressure button. Okay, so we get our temperature. We can check a pulse while we're there. Okay, so we want to do radial pulse, and get our oxygen saturations. While you're checking a pulse, you can also assess for skin color, skin moisture, and skin warmth. Okay, so what do we document on skin? Warm, dry, intact. Okay, depending on the color of the individual, is it appropriate? Is it gray or ashen? Is it pale? Is it pink? Is it dry? Is it wet? Okay, so you need to assess your patient based on their specifics. So we get that. What are we gonna do with that data? Are we gonna try to memorize it? Okay, you're gonna be really nervous, so you're probably gonna wanna have a little piece of paper with you, and it's okay. It's totally okay to write it down. Everybody has a different cheat sheet they use. I went through like 5 or 6 of them when I first started out.
I'm a little folded report.
Yeah.
Until I figured I could push the print button on the vital signs machine, and then
Oh,
it'll just spell.
sneaky. So yeah, and I just usually grab a sheet of printer paper and fold it in 4s and keep it in my pocket. So, but it's okay to stop and write it down. Now, is it okay to tell your patient what's vital signs he came up with? Why not? It's their data. So your blood pressure is this. Is that pretty typical for you? Do you know what your blood pressure normally is? So it's okay to do that. Again, it's patient-centered. It's involving them in their care, and that's very important. Okay. So we've got our vitals. I've walked around the bed. I've kind of checked to make sure everything looks copacetic. You see no lines. But I did notice when I pulled this back that he's got, for example, this is what we call noticing. So we want to notice things like bands. This looks like an allergy band to me. And let's see. I see it says here you're allergic to Demerol. Is that true? I'm still in general survey. Okay, so I'm going to ask him, and I'm confirm that. I need to confirm allergies. What happens when you take Demerol? So it's part of the conversation. How cognitively intact is this patient? Okay. On this side, we notice that he's got his wristband on. He's got a fall wristband. Okay, so we need to know that. What are some other things that might be hiding under the covers under general survey? Well, DVT prophylaxis, deep vein thrombosis, has a protocol which often includes compression stockings. So I see that he has what we call TEDs in place. Another thing that you might find are sequential compression devices. So are they on or are they off? They can be taken off in the morning. You're supposed to rest the patient's leg and skin. So they're off. How long have they been off? Does he have a compression pump? Is there an order? So that's something I would follow up on later, checking his orders. Okay, DVT prophylaxis. Okay, so we're just taking a peek there. All right, so general survey, you can see, you can collect a lot of subjective data. I think you guys have talked about the subjective data yesterday and the day before. So we're good there. So, okay, John, I'm gonna just start from your head and I'm gonna work towards your toes here and just kind of check you out. Is that all right? Yeah, that sounds good. Do what you gotta do. Okay. Never say you're sorry, never apologize for doing your job, okay? If you gotta wake up your patient, wake up your patient. They're not there for rest. This isn't a spa. Get in there and do your job, and your head-to-toe assessment is what you need to get done, because you're gonna have a patient load that's gonna require you to be effective, right? So John's good, he's already up. We've got his temperatures, his pulse, respirations, blood pressure, his oxygen sats look okay. At this point, we can start at his head. The key thing about a head-to-toe assessment, organize it from head to toe, okay? Everybody does it a little different. I like to assess head to toe on the front, okay? Listen to heart, lung sounds, and then I'm gonna dangle them on the bed. Then I'm gonna look at their skin. I'm gonna palpate anything I need to palpate. I'm gonna check for pressure sores or sore spots, reddened areas, and then I'm gonna listen, okay? I'm not gonna necessarily listen to the heart. Okay, now roll over. If it's somebody that can do that easily, maybe so. If somebody who's painful, like an ortho patient, post-surgical, maybe I'll wait until I'm dangling them or they're up in the chair. You go with that?
Oh, yeah.
Okay, all right. So.
Stop using the ortho patient though, that they're gonna have a lot of pain. Freaking out a little bit.
So we start at the head, and so what are we looking at when we just look at the face for inspection?
Are they relaxed?
Yeah.
Grimacing?
Are they relaxed or grimacing? So are they showing signs of pain? So we're inspecting for that. Inspecting for wetness, diaphoresis, is color appropriate to the individual. We're going to look for symmetry in the face. Okay, we're bilaterally symmetrical organisms. That's how humans are designed, all mammals. So do they look symmetrical? If I see something that looks abnormal, and we're all, if you look at yourself, everybody's a little a little asymmetrical. Okay, but if I see something significant like a drooping lip here or something, that's a significant finding. If I see the absence of a nasolabial fold, look at the person next to you. Everybody has this crease right here. That goes away. That can indicate there's some loss of muscle tone in the face. But they have normal wrinkles, normal hair color, normal hair distribution for age, gender, etc. Okay, so we're just inspecting. Then you could do your palpation. Again, depending on your patient, you may do a more focused assessment if it was an unwitnessed fall and you're worried about a head injury. We'd probably want to have the patient turn their head, look at the back, just look for any signs of bruising. You might notice in the neck if they've got any sort of distension of the veins that looks abnormal, that could indicate some change in fluid status. Okay. In terms of palpation, you can palpate, and they describe that pretty nicely in Smith and Duell. What are we palpating for? What are we looking for? Bumps, lumps, bruises. We're looking to make sure that there's not any little critters in the hair. Okay. So, where do you guys stand on gloves for exams?
We use them here with the mannequins. We don't always use them here. I guess, we're probably on the same page. I would
some
use gloves
people-
for absolutely everything that you
Yeah,
need a patient.
some patients find gloves. They want you to wear gloves. Some patients find it less, more sterile, more clinical, less personal. So you have to kind of feel out the situation. But
I would agree with that.
yeah.
Unless, of course, body fluids, I mean, that's not
Yeah.
negotiable, ever.
Right. If it's wet and it's not yours, gloves. Okay, that's just your bottom line. All right. So we've done our palpating there and our inspecting. I'm looking also at the palpebral fissures, the eyes, to notice if there's any droop, if the eyes look open normally. And one of my concerns with looking just inspection here, droopy eyes, change in muscle tone in the face, I'm worried about strokes or their baseline if they've had a stroke in the past. 85% of your patients are going to be over the age of 60. So, your stroke risk is increased, cardiovascular events, et cetera, so forth, things like that. So just what do they look like? Because as RNs, what we're looking for are trends or changes. We're kind of assessing, and we need to know what their baseline is. Oh, that's normal for them to have a droop on that side of the face. They had a stroke in 2002. Okay, great. So head and face, we're looking at the pupils. How much do you want me to go into neural status stuff?
They haven't gotten the neuro unit yet, but
Okay.
I would do what
For
we are expecting them to do on their basic shift test out, which will be the next time, and they will have learned it by then.
Okay.
So I guess what you and I would think would be expected as a new nurse going to take care of a patient,
Okay.
what they should do.
Okay. So I'm going to have a pen light, okay, and I'm going to have a stethoscope. So I guess we're pretending, but I'm just going